our speaker will be discussing diabetes, how it can be managed, and more importantly, how you can avoid becoming a diabetic. Darryl Dukes, many of you know him already because he's been here for 10 years. He's a registered kinesiologist, certified exercise specialist who's been a rehab supervisor in both the cardiac and the diabetic programs for the last 10 years. Some of you will know him already, but what you probably don't know is that he walks, cycles, is a keen photographer and a certified scuba diver. The only thing we're not sure about is his guitar playing. So please help me welcome Darryl to speak to us this evening. Thank you.
Well, thank you, and good evening, Take Charge. Looking over the audience, see lots of familiar faces. Good to see everybody. So, how did this whole thing come about, me being up here before you this evening? Well, it's a good 2-3 months ago now. Rob and I, in one of our lunchtime workouts here, we were on the Schwinn Airdynes out there. And as we often do, we talk shop, we talk about you guys and, what the best mode of treatment is. And then we talk about, the program in general. And then pretty often, actually, Take Charge comes up. As you know, Rob has been the driving force behind that. And Dukes says, you know what, we haven't had a diabetes talk for quite a while. He says, how about it? And I said, oh, well, okay, well, maybe, Rob, what do you think the topic would be? What would you want me to talk about? So Rob says, hey, well, how about everything you need to know about diabetes? And I'm thinking, well, no pressure there, Rob. But anyway, so here we are. Here's the title tonight, as you can see up there, Everything You Need to Know About Diabetes. I'm not quite sure I'm going to be really true to that, though, and I think you all understand that as well. But I think tonight what I want to do is just go through some of the basics. And maybe another subtitle that we could call this tonight would be, Diabetes 101. And just thought I'd try to give you a little bit of insight and what actually happens with the whole process of diabetes? How does it begin? How does it affect, how the cells work and that sort of thing? And then a little bit about some of the diagnostic criteria, symptoms associated with diabetes, and then, of course, as you're all familiar with here, lifestyle factors. So how does that impact on the whole diabetes thing? And can we actually prevent diabetes from occurring? And so that's going to be a big part of our talk tonight. But anyway, one of the things that I get is a regular newsletter from the International Diabetes Foundation. And as Leslie just kind of alluded to, diabetes is a worldwide thing. And just in the November issue of the newsletter from the International Diabetes Federation, they're stating that right now, worldwide, there are about 415 million adults around the world who are living with diabetes. By 2040, this is expected to be 642 million adults around the world living with diabetes. And this comes out to about 1 in 10 adults around the world by that date, 2040, will be living with diabetes. An interesting side note on this whole thing was that 75% of these adults around the world living with diabetes come from developing countries, where people in those countries are dealing with rapid urbanization. They have poor diets, and their lifestyles are becoming increasingly sedentary. And so these are all things that promote the development of type 2 diabetes. But interestingly, and in the same newsletter, a glimmer of hope, according to the IDF, up to 70% of all cases of type 2 diabetes can be prevented by adopting healthier lifestyles, by implementing policies and environments that promote healthy living, healthy diets, and physical activity. So, there is some light here with some of these very sobering statistics. So, how are we doing on the home front, though? Well, here we can see on this slide, we have diabetes in Canada, the prevalence by province and territory. And as we look across this great nation of ours, we can see that Newfoundland, Nova Scotia, and Ontario have the highest prevalence rates of diabetes in the country, while Nunavut, Alberta, and Quebec have the lowest rates of diabetes across the country. Not so long ago, the Canadian Diabetes Association produced a document, and it was called Diabetes, Canada at the Tipping Point. And in that document, they mentioned that currently, it's estimated there's 2.7 million Canadians living with diagnosed diabetes. There's another 1 million Canadians who are actually living with diabetes right now, but they actually don't know it. They haven't been diagnosed yet. And currently, that comes out to about 1 in 4 Canadians who are living with either diagnosed diabetes, undiagnosed diabetes, or another condition called prediabetes. And prediabetes, I don't know if you've heard that term before, that refers to individuals who are living with blood sugar levels that are a little bit higher than normal, but they yet haven't reached that threshold where they would be diagnosed with actual diabetes. Looking at it another way, diabetes in Canada, according to age and sex, very simply, the older we get, the higher there is the prevalence of diabetes. And it seems, according to this slide, that the sharpest increase occurs after the age of 40 years. And then we can see how it goes, but reaching its highest prevalence in the age 75 to 79 age groups. All right, so from here, what I would like to do is just kind of give you some of the Diabetes 101 basics, all right? How does blood sugar affect the body? How does blood sugar affect the cells? How is it used, to provide energy and things like that? All right, so here we go. Here's our stomach. And, we have a meal. We eat a meal. And that food, of course, gets digested. And if you have diabetes, your body lacks the ability to control your blood glucose. And that's the primary sugar that circulates in your blood. A lot of people think, well, diabetes, if I have diabetes, I must have eaten a lot of sugar, or I must eat too much sugar. It's actually really not the case, all right? So when a person, though, without diabetes consumes food that contains carbohydrate, there's 3 main nutrients that we consume. It's carbohydrate, it's fats, and it's protein, all right? But it's the carbohydrate that's the main source for glucose in the blood. And it's absorbed through the gastrointestinal tract. Once we've eaten it, it gets digested. And the glucose goes from the stomach. It absorbs into the tissues, and it ends up in the bloodstream where it's circulating around in the bloodstream here. And that's represented by these blue dots here. All right? In response to that, you've eaten a meal, the glucose goes into the bloodstream, blood sugar levels start to go up. And this organ down here, called the pancreas, senses that. And the pancreas, in response to that, produces a hormone called insulin. And so in response to the rising levels of blood sugar in the bloodstream, the pancreas sends out insulin. And what insulin does is these rectangles, these blue rectangles here, represent a cell. And so we have this glucose and we have this insulin circulating through our bloodstream, but it's not doing any good there. The glucose is needed inside the cells to provide the cells with energy and to enable them to function. And so as we have it here, the glucose is circulating through the bloodstream, and this cell here, we can see that it has a capacity up here for a blood glucose level, but it's actually way down here. And so this cell needs to replenish itself. And the most common places where glucose is stored in the body is muscle cells, and if we have an excess, in fat cells as well. And so what will happen is, the glucose, again, we have it circulating through the bloodstream, but the insulin will attach itself here to these receptor sites on the outside of the cell wall. And what that does, the insulin acts like a key that will open up a cell door that will enable the blood glucose to enter the cell and then to replenish the glucose and the energy supply within that cell wall, within that cell. All right, so here we go. We have the insulin coming in. It docks onto the receptor site. In response to that, this door opens up and the blood glucose goes from your bloodstream into the cell. And what that does, it helps to maintain normal blood sugar levels within the bloodstream, because the glucose is now no longer circulating in your bloodstream. It's in the cells where it belongs and where it's doing its functions, providing energy for the cell to be able to function. That's not the case with diabetes. So with diabetes, a few slides back, we saw that picture of the pancreas, and we saw that in response to increasing blood sugar levels, the pancreas produces the hormone insulin. All right? So in diabetes, there's two things that can be wrong with that pancreas. The pancreas either doesn't have any capacity whatsoever to produce insulin, or for some reason the body becomes insensitive to that insulin, and so therefore it doesn't work really well. So in my example here, on the top cell here, example A, this represents type 1 diabetes. How many of you have heard the term type 1 diabetes? Lots of hands going up. We used to refer to it as juvenile onset diabetes. So this would be the diabetes that you would typically see in childhood. But of course, type 1 diabetes can actually occur any time during the lifespan, but it actually is more common in early childhood. And there seems to be two very particular or very specific peaks where we see an increase in the incidence of type 1 diabetes. And that is in children aged 4 to 7 and children aged 10 to 14. This is where we see type 1 diabetes develop the most. So what happens with type 1 diabetes, the pancreas, due to an autoimmune problem, an autoimmune disease or an infection, it's totally destroyed the pancreas's ability to produce that hormone insulin. It doesn't produce any more insulin. There is no more. And so, of course, with that, if the insulin here can't dock into those receptor sites, the cell door is not going to open. All right? So that cell is going to have a really low level of glycogen inside, and the result is that in the circulating bloodstream we have high blood sugar levels due to that reason. And then, of course, what is the solution for individuals living with type 1 diabetes? What do they have to do? I hear some people saying, yeah, it's insulin. So they have to have an outside source of insulin to be able to accomplish that task. And so they take injections of insulin. All right. Down at the bottom here, we have what represents type 2 diabetes. Now I'll just back up just for a second. So type 1 diabetes, that represents about 5 to 10% of all people who have diabetes is type 1 diabetes. All right. The B example here, dealing with type 2 diabetes, that accounts for 90 to 95% of all cases of diabetes. All right. And what happens in type 2 diabetes is these individuals are actually very opposite in one way, in that they have all the insulin that they need. All right. There's no shortage of insulin in type 2 diabetes, at least initially. All right. Over time, that may change. But what happens is, even though the insulin does its thing, it docks into that receptor site where it's supposed to, the cell does not recognize it. And so while the cell door will still open, it's a much harder process, all right? And the body has to work a much harder in order to get that blood glucose from the circulating blood into that cell where it can do its job. It does happen, but in response to that, the pancreas really has to work hard. And it's shooting out a whole bunch of insulin. And in response to that, also, your body sensing that, oh, you know what, we're having a hard time getting glucose or fuel into those cells, we better pump out some more blood sugar. And so that kind of keeps blood sugars high in the circulating system. This term, again, is called insulin resistance. And we're going to be talking about that, hitting on that several times this evening. So that, in a nutshell, is what happens in type 1 and type 2 diabetes. In type 1 diabetes, there's totally no insulin at all, or at least not enough that it affects the blood sugar in any way. In type 2 diabetes, there is enough insulin, and like I said a moment ago, at least initially, because what happens over time, and we'll see in just a couple of slides now, the pancreas begins to wear out over time. All right, and gradually, many individuals living with type 2 diabetes will be at some point required to take insulin to help them control their blood sugars, just because their pancreas wears out after a period of time. So, risk factors. So I've just got a slide here for type 2 diabetes. When it comes to type 1 diabetes, there's really no defined risk factors per se. It seems to be related excuse me, to exposure to certain viruses like the Epstein-Barr virus, the Coxsackie virus, and a couple of others. There's no cure, and as far as we know at this point, there is no way to prevent type 1 diabetes from occurring. It's a field of very active research. We've learned a lot about type 1 diabetes, but there's still not a whole lot we can do to screen for it or to prevent it from happening. Not necessarily the case with type 2 diabetes, however. Risk factors for type 2 diabetes are generally divided into two broad categories. So those risk factors that you do have a degree of control over, that you can do something about, and those, of course, that we cannot do anything about. And then, of course, as we saw on a previous slide there, as we get older, our prevalence of diabetes tends to increase. You're also at increased risk for type 2 diabetes if you have a first-degree relative with diabetes, a parent or a sibling. Also, if you're a member of a high-risk population, Aboriginal Canadians, African Canadians, South Asian Canadians. These are all ethnic groups that seem to be very predisposed and very vulnerable to developing type 2 diabetes. Also, if you have a history of prediabetes, that's that condition again where your blood sugar levels are higher than usual, than normal, but not quite high enough to be diagnosed with diabetes. And then, of course, a history of gestational diabetes. And so this is diabetes that occurs during pregnancy. It usually goes away once the baby is delivered, but thereafter both mother and child are at increased risk for developing type 2 diabetes. And then some of the lifestyle things over here, we have physical inactivity, overweight and obesity, and more specifically where we store that extra fat. So-called abdominal obesity. And then, of course, our blood pressure and our cholesterol levels are also related to the development of type 2 diabetes. Down here at the bottom, does this strike you as kind of like why would that be? What would be the relationship between schizophrenia and type 2 diabetes? Well, in that instance, the mechanisms are far from clear. We do know, however, that there is a disproportionate number of individuals who suffer from schizophrenia who are also living with type 2 diabetes as well. And again, this has to do with many factors, including cellular and genetic factors. It has to do with certain societal and social conditions as well. And they all seem to just come together and create the perfect storm for individuals living with schizophrenia. All right, so are there any warning signs? How do I know if I've developed diabetes? Well, there are several very common symptoms or indicators that would lead you to think that you may have developed diabetes. And among these, frequent urination, weight loss, a lack of energy, and excessive thirst. So, looking at these. Frequent urination and excessive thirst are actually very closely related, all right? So your body, normally your body reabsorbs glucose as it's filtered through your kidneys. But once that blood glucose level reaches a certain threshold, the kidneys are no longer able to handle that. And so the kidneys say, you know what, we've got to do something with this extra sugar here. And so what it does is it starts to create more urine to get rid of it. All right, and so of course, if you're developing and creating more urine, you're going to need more fluid to be able to do that. All right, so it becomes a kind of like a vicious circle. So you're urinating a lot, and to replace that, you're drinking a lot. You have an excessive thirst, and it just kind of keeps going around and around and around like that. Of course, until they get the diabetes under control. Actually, the weight loss and the lack of energy are also closely related. You may recall from the previous slide, if there's no insulin there and there's no glucose getting into those cells to provide it with the energy that it needs to do its thing, then the result is a lack of energy. You feel fatigued, you're just not at the top of your game. And then if that continues long enough, the body and those cells need to get their fuel somehow. All right, and so what they do is the body, if it can't get it from glucose, it'll get it from somewhere else. And what it starts doing is using body fat, and it actually starts using lean muscle mass as well. And so the combination of those two things, providing energy, result in weight loss. Now, another symptom that could be up here as well, that's also quite common, is blurred vision or changes in your vision. Due to these changes in your, with the frequent urination and the excessive thirst, it just affects the way the circulation goes to the back of your eye over the retina, and it actually affects the curvature of the lens itself. Not so long ago, I was talking to a gentleman, and we were talking about his type 2 diabetes, and we got talking about, well, how long have you had diabetes, and how were you diagnosed, what were your symptoms? And his very first symptom was he was driving out of a parking garage and he noticed that his vision was blurry. And that was the first indicator that he had. And so obviously he recognized that blurry vision isn't a normal thing. And so off he went to his doctor, and in short time the diagnosis was made of type 2 diabetes. So how do we diagnose diabetes? So if you go, obviously, there's reason for you to go to your doctor. They'll do a blood test. And the first indicator that they'll look at is your fasting blood glucose. And so fasting defined as having no food intake for at least 8 hours before you had that blood test. And if your blood sugar is 7 millimoles or greater, then that's an indicator that you have type 2 diabetes, or you have diabetes of any type. The next test down is called an A1C. How many of you have heard of an A1C? Okay, lots of hands going up. All right, that's great. I'm going to talk more about A1C in a moment, but suffice to say at this point that an A1C greater than 6.5% in an adult is an indicator of diabetes. The next test that they can do is a 2-hour PG and a 75G OGTT. Now, what in the world is that? Have you ever heard of that? Any hands going up? Okay, one hand going up. Okay, so OGTT stands for oral glucose tolerance test. All right, and what they'll do in this situation is you'll go to the lab, they'll sit you down, and they'll give you this glass of, it's actually 75 grams of glucose, all right? And you got to drink that down, all right? And it's really sweet, and it'll almost make you throw up. But you got to get it down, and then they'll be measuring your blood glucose at intervals after you've drunk that stuff down. And then the 2-hour point is the really important thing, the measurement that they do. And if your blood glucose goes greater than 11.1 millimoles, then that's an indicator that, again, you have diabetes. The final thing that they will look at, although this isn't as refined as some of the other ones, but if they do a random blood glucose, like check your blood glucose anytime during the day without any regard to when the last time was that you ate. And if your blood glucose is greater than 11.1, and with this one, they usually take a look at if you're experiencing any symptoms as well. And if you are, then that is, of course, is an indicator. But they won't do this test just once. they will actually reconfirm these tests, and usually the one that's of the highest value, and to confirm whether or not it really actually is diabetes. All right, so this slide here, so the top portion, we all know the analogy of the iceberg, right? So the top part that you see, let's see, where'd my cursor go? Here, there it is, all right? That's actually the smallest part of the iceberg, right? So this represents the 2.7 million Canadians who are diagnosed with diabetes. They know it, they're managing it, they're living with it every day. The bottom part of the iceberg, the part that we can't see here, represents those Canadians who are living with pre-diabetes. And that number is estimated to be upwards of 5.7 million Canadians who are living with pre-diabetes. And that is, they have no clue that their blood sugars are elevated. And it is really important to know whether or not you do have pre-diabetes. Upwards of 50% of all individuals with pre-diabetes will go on to develop full-blown diabetes. All right, it's a big problem. And it's also important to know if you have pre-diabetes, because it's during that period of time that a significant number of individuals develop some of the complications that go along with having diabetes, heart disease, nerve problems, problems with retinopathy and things like that. So it's really important. So what are the diagnostic criteria for pre-diabetes? So if you remember from the previous slide, if your fasting blood glucose is 7 or greater, you would be diagnosed with diabetes. Pre-diabetes is a fasting glucose of 6.1 to 6.9, all right? Just a little bit lower. How much of a difference do you think 6.9 and 7.0 makes? Not much. We had to come up with some cutoff point somewhere, to be able to categorize things, right? So your risk is, really high there. And then, of course, there's that 2-hour glucose test, oral glucose tolerance test. And those are the blood sugar values that you would see with that. And then, of course, the A1C here at the bottom of 6.0 to 6.4. So if your blood sugars are in these ranges, and usually when you have a blood test, you would see the top and the bottom one here. It's not every day that you have the oral glucose tolerance test. So those are the values that you want to be aware of when it comes to pre-diabetes. All right, now this is a really busy looking slide, I admit, and it's got lots of lines and things like that, but I think we can get ourselves through it, all right? And what I would like us to do, if I can find my cursor here again. All right, so we're going to start with the bottom line here. Everybody see that where it says fasting blood glucose? We're going to come across this line, and I'm going to come right over to right here where it says type 2 diabetes. All right, so that's the point where this individual was diagnosed with type 2 diabetes. And let's just say for illustration purposes, it's November 19, 2015. That you've been diagnosed with type 2 diabetes, all right? Let me ask you, when do you think problems with blood sugar started to happen? Is it just kind of like overnight, one day you were perfectly okay, and then the next day suddenly you're diabetes? Or is it something like, oh, I feel diabetes coming on, something like that, How far back do you think you need to go to trace where the problem started to begin with that insulin resistance? Well, research has showed us that we can go back as much as, say, 3 years, 5 years, 8 years, even 12 years before the diagnosis of diabetes has been made, where things start to be a problem with your blood sugar. And what happens though, initially, remember I said that people with type 2 diabetes, they have all the insulin that they need, all right? That's not the problem. But what happens is your body is able to produce enough insulin to look after that for the first little while, all right? But gradually over time, if we look up here, So insulin secretion, your pancreas is working really hard to maintain that normal blood sugar level. And it's able to do that for quite a period of time, as we can see down here on the bottom. But gradually, it starts to catch up with your pancreas, all right? And during that time, we can see that insulin sensitivity, it gets less and less effective in doing the job that it's supposed to do. And so our sensitivity starts to decline here, all right? And our pancreas is just working really hard, and finally, it just can't keep up with the demand, all right? And so by the time an individual is diagnosed with type 2 diabetes, their pancreas has already lost 50% of its capacity to produce insulin. And what's likely going to happen, that decline is going to continue. Even though diagnosis has been made and some individual, and the individual is being treated for diabetes. You can do a lot of things to alleviate that, but by and large, that's the process that still happens. And then during this time as well, we've lost our pancreas's capacity to produce insulin. We're less insulin sensitive. But during that time, certain associated risk factors, remember a slide or two back, I talked about blood pressure levels and cholesterol levels being related. So, diabetes affects much more than just your sugar levels, all right? It's a total metabolic disease. It affects multiple systems in your body, and among those are the way that, your body handles cholesterol and even your blood pressure as well. And then during that time, of course, it can lead to the premature development of buildup of plaque in your arteries, so atherosclerosis. And then at the same time, concurrently, there can be problems with microvascular circulation, or the microvascular. I'm going to talk about those in just a moment. Complications that deal with the small blood vessels in the body. And these are all developing, and these often manifest themselves at the time the individual is diagnosed with diabetes. Sometimes these other complications emerge first, all right? And then the diagnosis of diabetes is made after that. How many of you in here are familiar with the term the double whammy? Have you ever heard that one before? No? Anybody experienced that in here? Oftentimes, individuals will end up in the hospital with a heart attack or an acute coronary syndrome, and they'll be working them up for that, and then the doctor will come back in and says, oh, by the way, did you know you also have diabetes? All right, it's a big shock for individuals. But the two of them have kind of grown together. They're very much related. So, what can we do here? Well, just before we get to that, just say a little bit more about the complications of diabetes. Again, there's two major types of complications with diabetes, what we call macrovascular complications. They deal with the large blood vessels of the body. So the coronary arteries, the arteries around your heart wall, the arteries down your legs and things like that, the arteries in your head, all right? And so it increases your risk for developing stroke. It increases your risk for heart attack, for all kinds of heart problems, and then the extremities as well. So the circulation down your legs gets blocked off, and so when you walk, you get that very peculiar cramping feeling in your leg. It's called peripheral vascular disease. All right. So these are all possible complications, so-called macrovascular complications that come from diabetes. And so as I said a moment ago, the microvascular complications are complications that deal with the small blood vessels of the body. So the circulation in the back of the eye, they can be a problem, and so you develop retinopathy, cataracts, glaucoma, you have problems with your eye pressure. It also affects the circulation in the kidneys, and so it leads to a condition called nephrology. And your kidney function gradually starts to decline, and you start to spill protein in your urine and things like that, and they're testing you for that. And then, of course, it can also affect the nerves, and there's two types of nerves that diabetes can affect. The first, neuropathy, it's called, it affects the extremities. So you lose sensation in your fingertips or in your legs, in your feet, your toes, and things like that. The other type, it's called autonomic neuropathy. That's where the diabetes affects nerves that control other systems of your body. For example, sexual function. So oftentimes individuals with diabetes will have sexual dysfunction. It can also affect how your body digests food, and it just doesn't digest very well. It can also affect things like blood pressure and your heartbeat. And one of the things with diabetes, so oftentimes people, when they have a heart attack or they have narrowing in their coronary arteries, they'll get pain in their chest, or they'll have angina, when you walk upstairs and those types of things. But in autonomic neuropathy, it affects the nerves so that you may not feel those symptoms that somebody else would feel without diabetes. And so some of these complications can be a real problem, as you can imagine. All right, so what are some of the things that contribute to diabetes? All right. So we knew for sure that overweight and obesity is a potent initiator of that insulin resistance. It just totally affects the way your body handles that insulin, and it makes you resistant to it. And because of that, the effectiveness of the insulin leads to that increased demand on your pancreas, and gradually you just can't keep up. And finally your insulin production declines, and that leads to type 2 diabetes. Now, one thing I do want to say about being overweight and things, it's easy to stand up here and say, you know what, you need to lose weight, all right? That's going to help you out, your blood sugars are going to be better. It may be true, all right, if you lose some weight. But I want to say, and I want to make this very clear, that obesity and overweight is a very complex issue, all right? And so it's not a simple thing. And so a lot of people, due to a lot of different factors, we can say that, if you ever heard that energy in equals energy out, and if you're able to do that, then your weight will stay the same. Well, that may be true. That might be the physics, so to speak. But when it comes to biology, everybody is a little bit different in the way that they handle that. All right, there's a lot of individual factors. It deals with behavioral things. It deals with genetic things. It deals with social things. It deals with ethnicity and things like that. So obesity and overweight is a really complex issue, all right? And it's not a simple thing. But as we're going to see here in a moment, there are some really great ways, all right, that even though you may be carrying some extra weight around, you can still control your blood sugars and things like that. But you don't have to lose a ton of weight either when it comes to that. Just 5 to 10% can greatly improve your metabolic parameters. This is just to look at it in a little different way. Body mass index, BMI, stands for body mass index. And so the higher our body mass index is, the greater our risk for developing diabetes. The so-called normal range is between 20 and 25 for body mass index. But the one thing that you need to keep in mind when you're dealing with body mass index is that it doesn't differentiate between muscle mass and fat mass, all right? It's just a number, all right? And that total number. And so there are a lot of people out there who have, a lot of muscle and not very much fat, but they're heavier. And so if you were just going by body mass index, you would say, oh, listen, you may have a health problem, but that's not the case for these individuals. All right. So again, you need to be careful when you interpret body mass index, but the trend is there. All right. There's no doubt to that. The heavier we tend to be, the greater our risk for developing type 2 diabetes. Just last week I was at a diabetes educators conference, and a Toronto endocrinologist was presenting actually on this very topic. And so I put up my hand and I said, okay, doc, I said, what is that relationship? Okay, how close is the relationship between weight and type 2 diabetes? And he says, well, I'm going to answer you with a question. He says, what is the relationship between smoking and lung cancer? And so, it kind of took me back for a minute. I said, okay, so, that's a rather strong relationship, right? And we would all agree, I think, right? And so he went on to say, though, that, we know that weight and diabetes tend to go together. It's a very close relationship. He says, but we also know that there are some heavy people who don't have diabetes, all right? And there's also some people who don't have a weight problem and who do get diabetes. And so, it's not so clean cut, but there is a definite association that's right there. The second very potent initiator of that insulin resistance are our activity levels. And perhaps this one is more important than all of them, all right? And we know that only 15% of Canadian adults attain the recommended activity levels. Only 7% of our Canadian youth attain the recommended activity levels. And we tend to spend, adults, we spend 9.5 hours a day, and our kids and youth spend just over 8.5 hours a day in sedentary pursuits. Well, what are these sedentary pursuits? Well, our kids are sitting in school, where they should be, by the way. We sit at desk jobs. We commute for an hour before work and an hour after work, going back and forth. When we get home, we have a lot of screen time, as our picture here illustrates. If physical activity is so important in preventing and managing, by the way, diabetes, I think it would behoove us to figure out, what it is that we can do in order to get people to be more physically active. And this has been the subject of some research. Back in 2007, the Physical Activity Monitor was a study that they did on Canadian adults. And their job was to identify the most frequently observed barriers to being physically active in the general population. Anybody want to hazard a guess as to what number one was? What's the biggest barrier to participation in physical activity?
Video games. Watching TV. Time.
Nope. There, I heard somebody say it. Time. Yes. So the perceived lack of time. All right. How many hours are there in a week? What is it? 168. 168. Yeah. So some people seem to be able to get physical activity in those same 168 hours, but yet there's lots of us. In fact, the survey said 72% of the respondents said lack of time was the number one reason that they weren't physically active. Any guesses on what number 2 and 3 were? There was a whole list, but I just went 1, 2, and 3 here. Anyone else? No? I know, I'm really making your reach here. Okay, number 2, in which 64% of the respondents says was lack of energy or fatigue. All right, just too tired, and maybe that's why, we end up on the couch like that. And the third one was lack of interest or motivation, and 62% of the respondents mentioned that as the reason why they're not physically active. All right. So here's, again, another way of looking at the whole activity thing and risk of developing diabetes. And we, go descending from down at the bottom there. So somebody who's getting greater than 7 hours of physical activity a week, so they'd be getting an hour a day, 7 days a week, all the way down to less than half hour a day. All right. And as you can see, as activity levels decrease, the risk for developing type 2 diabetes increases. All right. All right. So here's something, just to think about. All right. So the relative risk for developing type 2 diabetes is cumulative. And so we've just seen the contribution that being overweight and being physically inactive makes, to developing diabetes. There's other factors that come in there as well. All right, certainly our diet, although I'm not going to be touching on that so much tonight, or not at all actually. So a physically inactive individual with less than 30 minutes per week of exercise, who consumes an unhealthy diet, and we can define that unhealthy diet as lots of fast food, low fiber, lots of sugary drinks, that sort of thing, high fat, and is just modestly overweight. So your body mass index 25 to 30, so not huge, would have a 30-fold increased risk of developing type 2 diabetes compared to somebody without some of these characteristics. And this would translate to a lifetime risk of nearly 100% developing type 2 diabetes. All right, so what can we do about that? One concept that I would like to talk about, and actually I'm great to see the number of hands that went up. So most of us are familiar with what hemoglobin A1C is. And basically, hemoglobin A1C is a test that reflects your average blood sugar or your average blood glucose levels over the past 3 months. And why the past 3 months? Anybody know? This is a test that your doc would do approximately every 3 months on you if you're living with diabetes. So why 3 months?
Red blood cells are replaced every 3 months.
There you go, exactly. The red blood cells are replaced every 3 months. And of course, what is it that gives red blood cells their color? Hemoglobin, there you go, it's right up there, yes. And more specifically, there's a certain type of hemoglobin that is a component of the cells, and it's called hemoglobin A1. And so simply put, the A1C is a measure of how much sugar is stuck to your red blood cells. And they actually stick to that substrate of hemoglobin called A1. And the thing about A1C, though, is that the higher your A1C level, it usually indicates the poorer your blood sugar control and the higher your risk of developing diabetes complications. So it's really important to keep that A1C number as controlled as you can. So this next slide that I'm going to go into deals with the importance of that A1C. UKPDS findings, all right? That was a study that was done out of Oxford in England in the mid to late 1970s. It was a study that went on for 20 years, and it was called the United Kingdom Diabetes Prospective Study, all right? And what that study was all about, around this time, we really had no idea of, how much should your blood sugar be, all right? We didn't know a whole lot about the relationship between complications and blood sugar levels in A1C. And so this was a really landmark study. And so this study, they had over 5,000 participants, people who were newly diagnosed with type 2 diabetes. And they followed them for 20 years. And so what they found was, well, they had the study group and they had the control group. With the control group, all they wanted to do with them was keep their blood sugar levels under 15 and to have no symptoms. But the study group, they attempted to get their blood sugars down to a level of 6, all right, which is pretty stringent, all right. And if they were not able to do that by lifestyle measures, by diet and so forth, then they put these individuals on metformin, or they put them on some of the sulfonylureas like glyburide and things like that to get them down to that. And what they found with this study, though, was that any lowering of your blood glucose levels brought about very definite health benefits. And as you can see on here, for every 1% decline in your annual average A1C, those microvascular complications, those complications with your nerves, with your eyesight, things like that, decrease by 37%. All right, and so that's for every 1%, so it adds up. Peripheral vascular disease, all right, every 1% decline in that A1C decrease the risk of complications 43%. Heart attack, stroke, heart failure, and cataract extraction. So the message from this study was that control matters. Now at the same time, there was another study that was done. It was called the Diabetes Complications and Control Trial, and that was for individuals living with type 1 diabetes. And together, both of these studies showed that controlling blood sugar really matters, all right? And there's no way around that. If you can control your blood sugars, your A1C, you can greatly decrease your risk for developing diabetes complications. All right, how are we doing so far here? We good? We're coming to the end, all right? One of the best ways that you can control your blood sugar is, of course, we're all about that here at Toronto Rehab, right? Exercise, all right? We've heard that. And it's really interesting. So blood glucose uptake in the muscles occurs in two ways. And so you may recall at the beginning, I showed you those diagrams of the cells and how that insulin, helps to get that blood sugar from the bloodstream into the cell, all right? And that happens while you're at rest and while you're exercising. But the really neat thing is the second way that you can get blood sugar from your bloodstream into those cells where it's needed is by muscle contractions, all right? Exercise, walking, swimming, cycling, any kind of muscle moving, all right? It totally bypasses, even though you may have problems with insulin resistance, muscle contractions totally bypass that way of getting glucose into the cell. They are separate, but they are additive mechanisms, all right? And so, when, you're looking, I got type 2 diabetes, I have that insulin resistance, one of the best ways around that is for you to be physically active because the two of them together, they work together. So the effects of physical activity, a single bout, all right? You go out there, you haven't exercised in 2 weeks, just a single bout of activity. If you go out and go for a walk, it's long been known to increase insulin sensitivity. So even though, you have that insulin resistance, physical activity will decrease that resistance, all right? And that effect will last from 2 up to 72 hours. And another benefit along with that is that a bout of exercise results in a greater glucose storage, so your muscles will take in more glucose than they usually would if you were just sedentary. And it also helps to improve fat metabolism. Now, if you're thinking, well, I'm exercising so I can, just sit down and eat whatever it is that I want. Notice the last point here. It says exercise-induced improvements in insulin sensitivity can be partially negated by overfeeding, all right? So you still need to pay attention to your diet, all right? Yeah. All right, so here's some more benefits of exercise, so the evidence. So aerobic or resistance exercise, so walking, swimming, cycling, and resistance exercise by themselves, if you're doing them separately, they'll decrease that A1C value by about 0.7%, all right? And here's a really cool point, the next point here. The beneficial effect is independent of weight loss. So if you remember nothing else tonight and you're worried about weight and things like that, even if you don't lose an ounce, with your exercise program and your diet and all that kind of stuff, if you're active, you're getting those beneficial effects of increased blood sugar control, whether or not you lose weight, okay? And there's a dose-response effect. The more exercise you do, the greater the effect will be. So aerobic exercise, so this gives us our guidelines. So how much exercise do I actually need to do? All right, so it's 150 minutes per week, or that comes out to about 30 minutes a day, 5 times a week, and that will give you a reduction in your A1C of about half to 0.9%. And of course, there's that direct enhancement of insulin sensitivity that we just saw on the last slide. Last thing on this slide, it says anywhere from 24 to 72 hours, and it can be done by brisk walking. Now, one point that I would like to make here with that insulin sensitivity, all right? It's finite, all right, so to speak. It declines after a period of time. And so the lesson from that, the take-home message from that is you need to be regularly active in order to gain the maximum benefit from that insulin sensitivity. And so we would recommend individuals with diabetes need to exercise at a minimum at least every other day in order to keep that increased sensitivity going. So brisk walking is easy to do. It consumes both glucose and calories. And then the resistance training down below there. So 60 to 90 minutes per week, 2 to 3 times per week resistance training. That'll decrease your A1C by about 1% overall. And so the good thing about resistance training is, with aerobic training, typically, you're walking, you're cycling, you're using your lower extremities. You're not doing anything with your upper extremities. So if you add, a resistance training program that hits all the major muscle groups of the body, like you've been through here in the program, then, you're getting some really good benefit, and it helps to preserve your active muscle. And for those of us who have problems, knee problems, back problems, we're limited in our mobility, resistance training is the thing that you can concentrate on, that you can do. Because you can do a lot of resistance training activities just by sitting on a chair. All right? You can do bicep curls, all kinds of different things. All right. So we're almost to the end here. Now, earlier I said, can we actually prevent diabetes from happening in the first place? DPP stands for Diabetes Prevention Program. And again, this was one of those really big studies that really informed, diabetes management and practice. And so that was a study that was done over a decade ago. And what they did is they took individuals who were already diagnosed with prediabetes. So these were high-risk individuals for developing type 2 diabetes. So their average age was 51. These weren't young people. They had a high body mass index. 68% of the participants in this study were women. And importantly, almost half of the individuals in this study were from high-risk ethnic groups in the States. So African Americans, Hispanic and Latino Americans, etc. So what they did with these individuals, they broke them off into 3 groups. And so the lifestyle intervention group, they were given education and instruction on how to lose 5 to 7% of their starting body weight at the beginning of the study. They were shown how to eat a healthy, low-calorie, low-fat diet. And they were required to get a minimum of 30 minutes of physical activity 5 days per week. There was a second group that was put on the diabetes drug metformin. And for those of you who are not familiar with it, metformin is probably the most common diabetes drug. It's the one that they usually start you on when you're first diagnosed with diabetes. And what metformin does, it increases your muscle cells' sensitivity to insulin. So it improves glucose uptake through the muscles, and it also decreases the amount of blood sugars or glucose that your liver puts out. And so overall, it lowers blood sugar. And then, of course, we had the placebo group who were given neither of the 2 treatments above. So what were the results of this? It was absolutely astounding. And in fact, this part of the study was cut short because the results were so clear. And what they found was the group that did the lifestyle, they were able to reduce their risk of developing diabetes by 58%. And this was most effective in the group that was age 60 and older. All right? So if you're thinking, I've reached that point and it's not, any good for me to try anything, yeah, it really is, all right? You can still do a whole ton. The group that took the metformin, they were able to decrease the risk by 31%. And then, of course, there was no change with the group that didn't receive either of these treatments. Another way to look at that is if you were to follow these people over the next 10 years, all right, the lifestyle group. Now, some of these individuals, don't get me wrong, in the lifestyle group, they still went on to develop diabetes. But at the 10-year point, 4 out of 10 individuals in the lifestyle group would have gone on to develop diabetes. 7 out of 10 individuals in the metformin group went on to develop diabetes, and almost 100% went on to develop diabetes in the placebo group. So it really packed a punch. It was a really beneficial study to do. And this has been translated. The study was called the Diabetes Prevention Program, but the program now is available at some family health teams and things like that, and it's called Group Lifestyle Balance, if you've ever come across that. All right, so my final slide tonight. So I've given you a lot of information on diabetes, and so you may be wondering, well, what's my risk? And so I would invite you just to Google, all right? Yeah, you got it? Okay, good, I'm gonna turn it off now, right. So, CAN risk, all right? Google that, CAN risk, and you'll be taken to this site, And this is a risk factor, a risk tool that you can go through. It'll ask you questions, you know, about family history, about your weight, waist circumference. It will even show you how to measure your waist circumference. You can plug all of that information in here, and then at the very end, you total up all your points, so to speak, and it will give you a score. And it will classify you as either low, medium, or high risk for developing type 2 diabetes. So it's a worthwhile exercise. You know, diabetes is a big challenge for us these days, but you know, there's very definite things that you can do to, you know, if you've hit that plateau where you're pre-diabetic, that's your chance actually to turn the clock back. And for those of us who have already been diagnosed with diabetes and we're living with it, there are ways that we can manage that and decrease our chances for developing some of those very serious complications that are possible with it. So, all the best, everybody. Thank you for listening tonight. And I guess, yeah, if we've got some questions, we can open the floor. Yeah.